Good afternoon. I would like to welcome everyone to the PartSource Executive Webinar Series. Today's presentation, Translating the CMS COVID-19 Emergency Declaration Waiver for HTM Leaders, is being presented by Matt Baratich and Frank Painter and hosted by Joe Zaluzny. Before we begin, I'd like to review a few housekeeping items. First off, you have a control panel at the side of your screen. You can minimize and expand this panel. Second, you can submit questions using the question portion of the control panel. We will answer questions at the end of the presentation. If your question is not answered, we will respond to you individually after the event. All registrations will receive a link to the recording after the webinar. The information will be sent to the email address with which you registered for this webinar. And now please allow me to introduce our host, PartSource Executive, Joe Zaluzny.
Thank you, Colleen. Hello, everyone. Thank you for joining us today. My name is Joe Zaluzny, the Chief Revenue Officer at PartSource, and I have the honor of introducing our presenters. At PartSource, we partner with customers, suppliers, and experts to achieve results. We rise to overcome challenges in times of adversity, and we know that true partnerships grow stronger after navigating challenges together. That is the type of partner PartSource is committed to being for our valued customers through this pandemic and beyond. I'm pleased to introduce two partners today and exceptional leaders in the HTM community who are sharing their expertise with us today. Matt Baratich and Frank Painter will review the CMS Emergency Declaration Blanket Waiver for healthcare providers and extract relevant and actionable information for leaders across the HTM community, Biomed and Clinical Engineering. I'd like to share a brief background on each of our presenters. Matt Baratich is president of the Baratich Engineering and Consulting in Clinical Engineering, focusing on performance improvement and forensic engineering, providing incident investigation, litigation support, and expert witness services. He holds numerous professional certifications, including clinical engineer, healthcare facilities manager, healthcare risk management, and patient safety. He is a founder, past president, and fellow of ACCE. He is also the author of many publications, including the AEM Program Guide, Alternative PM for Patient Safety. Prior to joining Baratich Engineering in 1997, Matt was Director of Engineering Services for the University of Colorado Hospital and Director of Clinical Engineering for the Children's Hospital in Norfolk, Virginia. Frank Painter is professor and the Clinical Engineering Program Director in the Biomedical Engineering Graduate Program at the University of Connecticut. He is nationally and internationally recognized in the field of clinical engineering with over 45 years of clinical engineering and biomedical equipment service management experience. He has directed in-house programs at 2 large metropolitan teaching hospitals and managed 2 successful regional independent medical equipment service organizations. Professor Painter is a past president of the ACCE, chairman of the U.S. Board of Examiners for Clinical Engineering Certification, and chairman of the Healthcare Technology Certification Commission. Please join me in welcoming Frank and Matt, and now I'd like to pass it over to Frank Painter to begin the webinar.
Thank you, Joe. Thank you, Colleen. It's an honor to be here. In my introductory slide, it was an old slide. I am no longer the internship program director. Carol Davis Smith is at University of Connecticut. Carol Davis Smith is now in that role, but everything else was good. So very good. So to start, I'm going to give a brief overview of the document, this waivers document from CMS. It's an important document, and it's good for us to know. So I'm going to just give a quick overview, and my presentation is not meant to cover each point and change that's been made or waiver that's been declared, but to take a few minutes just to summarize the document at a higher level. Matt, however, will be digging into the medical equipment maintenance waivers, and so we look forward to that. So let's see, to begin, this document is dated May 15th, not long ago, but it's interesting. The document has come out in iterations, and each time they add a few things. Like, for instance, this most recent edition added ADA references, American Disabilities Act, and somehow they left that out of the previous document. And it also added ambulance services in. So as you can see from this list, the waivers get involved, affect nearly every nook and cranny of the healthcare delivery system, all of these areas. So one thing about the document is the theme of the changes or the waivers is to temporarily reduce some of the burdens on providers so they can better address patient care during this pandemic period. So it's really wonderful that CMS acknowledges that hospitals are struggling, and what they're doing here is to make some temporary adjustments so that we can cope with it. So next slide, please. So as I was reading the document, I found it, the various reasons that CMS gave to make changes was really interesting. So before we talk about what they did, I thought we'd spend a few moments and talk about the whys. So for instance here, the patient-centered justifications are, better, more efficient treatment of patients in this surge situation. Allow clinicians to focus on patient care at the bedside rather than on documentation or other things that that I guess consume clinicians when they're trying to, that interfere with them providing patient care. So we can see some flexibility on CMS's part. They said they wanted to allow the staff to deliver care to a larger number of patients because we do have an influx of COVID-19 patients, and being able to focus on them is important. It also allows access for patients to the system, and they made changes to use practitioners to the fullest extent possible. Now that's an interesting phrase, but what it means is, so for instance, an RN who's licensed as an RN has, within their license, they have the ability to do from A to Z, but perhaps the hospital has picked off a few at the bottom and a few tasks at the top and assigned those to other providers so the nurse can focus on certain things. Well, this has allowed the hospitals to, quickly, without a lot of documentation, ask the clinicians to do more, but only within the fullest extent possible, that is possible within their license. So, and they also talk about, for instance, if a nurse had a license that was due to expire on April 1st, and because of their heavy workload and lack of people in the state agency available to work with them to renew their license, if their license expired recently, yet they're continuing to practice and the hospital feels comfortable, they can continue to let those kinds of people practice temporarily until this justification is over, or until this waiver document is, the effects are terminated. So very good, let's go to the next slide. There's a few more justifications here I thought worth mentioning. So what could possibly affect us in HTM? Well, we have a problem with scarcity of resources, particularly focusing on PPE, of course. So one of the things that CMS has allowed is reuse of PPE if it's prudent and if it's appropriate. In the past we've not reused PPE just to be careful, but now they're allowing it if you have shortages in those areas. The next one is allow physicians to perform responsibilities remotely as appropriate. So this is sort of important. In other words, CMS is allowing a wider use of telemedicine and telephony and telehealth. And so this is a big deal. We're going to talk about it just for a few seconds, a little in the next slide, but allowing clinicians to use wider use of telemedicine and to bill for these previously unbillable services, that is a phone call or a Zoom connection or some other such thing, is what CMS is now allowing. And then third bullet, allow these hospitals to meet the needs of the communities during this emergency And then, of course, ensure patients are safely cared for is important. So let's go to the next slide. So here's some of the changes. You know, this of course is not an exhaustive list. As I mentioned, these are for overview and thematic purposes only, and most are not related to HTM and clinical engineering. So to start, it's really interesting. This, you see the phrase underneath the title there, must be consistent with state's emergency preparedness or pandemic plan. CMS has gone to great lengths to analyze what clinicians do and to maybe temporarily waive some of the things they're asking patients to do. But whatever takes place, we can't do less than the state's emergency preparedness or pandemic plan. Our actions must be consistent with that. And in fact, that phrase is most often mentioned in the whole waivers document. You know, this phrase is repeated, you know, tens of times. Okay, so let's look at some of the changes here. Flexibility during clinical staff shortages. So of course, we're gonna have a few less qualified staff. So their qualifications may be relaxed, their credentialing may be relaxed, the extent of their responsibilities may be relaxed, and being used to the fullest extent possible. So CMS is allowing hospitals to use their staff in a different way, not so structured as they used to. This next bullet is what we were talking about before, the acceptance of substitute technology. Now, in particular, it mentions telehealth billing is now acceptable for telephone calls to evaluate, manage, counsel, and educate patients. So rather than doctor's visits or you know, screening patients, you know, come in, pre-admittance screening and that sort of thing, they're allowing telephone calls to be an acceptable substitute. So now, as a sidelight, there's a whole lot of discussion in the industry about the necessity to grow telehealth services in the future. There's a lot of pundits who are, you know, saying that telehealth will be a more common technology. Telehealth will play a bigger role in healthcare. So a message to the HTM community, get ready. Become telehealth experts. Understand all the parts and pieces of a telehealth technology and be ready to service it. So the next bullet, you know, we've all been, we had an old nursing wing that was closed 5 years ago and is now used for storage or some other such thing, maybe a few offices in it. And we cleaned it out and got it ready for overflow, expansion of beds, or maybe we put a tent in the parking lot, or we opened up the basketball arena nearby and put beds and started to staff it. Well, what CMS is saying is these new locations, they're giving some flexibility on going and adding those. They're just saying, you know, do what you need to do and let's waive the limits or waive the documentation. And they're also talking about careful reuse of limited supplies, as we mentioned. So next slide. Okay, so here they sort of, to go along with this, they're reducing the requirements for written policies, procedures, and documentation for surge sites or surge facilities. In other words, they're relaxing the rules. And they're relaxed reporting and documentation timeframes. So there might be, you know, hey, you needed to submit a summary report on this patient within 72 hours of them being discharged, or, you know, within 24 hours after the completion of this procedure, there needs to be a report in the record. Some of those timeframes are being relaxed in the face of extra work. And the third bullet, waive rules and restrictions so hospitals can get paid for patients who are discharged or moved to accommodate. So what this is talking about is sometimes, you know, CMS said, well, you know, if a patient came in for this, we expect that kind of care plan and they need to stay in the hospital for this much. But if the hospital becomes overwhelmed with COVID-19 patients, you can discharge them early, you know, even though they don't meet the requirements for having been treated properly, you can still bill for it. So they're a little flexible on that. And then the last two things, no quarterly fire drills because there's too much, you know, people-to-people interaction. So what they're doing is saying, do training instead, at least temporarily. and they have relaxed locations for hand sanitizer, I think mostly because we have limited supplies. So next slide. So in summary, as an organization, this document says, stay within your area of expertise and licensure, follow state requirements, but many of the CMS requirements are relaxed or waived. And just FYI for the rest of us, most of these do not pertain to, most of these changes do not pertain to clinical engineering or HTM. So, however, some medical equipment maintenance requirements are being waived. And this is a big change that affects clinical engineering and HTM. For instance, in this waiver document on page 22, it talks about waiving requirements for maintenance on dialysis equipment. And page 25 talks about hospital medical equipment. So I'd now like to turn the presentation over to Matt Baratich, who will cover these. Take it away, Matt.
Thanks, Frank. So in all of this material that's coming out from CMS, there is some good news for us in the HTM world, and it's about PM. We all know that there's a requirement from the accrediting organizations and from CMS that we hit the magic number of 100% compliance with our PM schedule. And that is challenging these days. I've talked to a lot of people in the field, and I would be very interested in during the Q&A session today to hear from you all about the challenges that you have been running into, particularly around PM completion, and what you've done about it. And the factors that I've picked up from talking to people out there is that, for example, ventilators, in many cases, particularly early on during the pandemic, particularly in some parts of the country, were in use all the time. And so it was hard to get to the ventilators to do PM. So we've always had the option to just mark scheduled PM as the equipment is in use, but it's become more critical. And of course, we really want to take good care of the ventilators over time. The other thing I've heard from people is that some HTM programs are short-staffed. That can be because people are out sick. It can be because there are inefficiencies in how we can use the staff to accommodate the additional infection control procedures that hospitals have implemented. And so we don't, in many cases, have the same number of people that we can deploy as efficiently to do PM. And of course, we're doing lots of other things besides PM, doing repairs, doing special projects. So lots of stuff, lots of stress on getting our PM done. And we have continued until very recently with some of these waivers to be under the gun to get all the PM done. And it was just not realistic. So the good news is we've got some relief for that. I've also heard that sometimes the things that we have on contract with external service providers, we have trouble getting the work done because they're busy, because they have travel restrictions, because our hospitals put restrictions on who can come into the hospital and where they can work. And so we have had challenges being able to rely on the external service providers as well as our own in-house. But so there's a little bit of a, maybe you can call it a silver lining. I think many of us have been following the right to repair movement. And the issue, of course, is that sometimes some manufacturers are very restrictive on the amount of service information that they'll provide or parts that they'll sell or training that they'll offer. And that's always been an ongoing problem. But in this pandemic, that's become particularly acute because we really need to be, there might be a ventilator that we can't get the service provider to come in and take care of. we could take care of it if we had the information, and in some cases we don't. And so I think there's maybe a little boost to this right to repair movement by saying, absolutely, we should have had better access to service information in this pandemic, but the same reasons apply during normal circumstances, and maybe we'll get some a little bit of momentum. We can see a little bit of action in some states around the state legislatures around the country. So next slide. Let me give you some orientation to this blanket waivers thing that we're talking about. The orientation, of course, CMS, we're talking CMS is the Center for Medicare and Medicaid Services. Why do we care about CMS? Because almost all hospitals depend heavily on funding from Medicare, and to a lesser extent to Medicaid. And so we in the hospitals have to do what CMS says, including their mandate to do PM 100% on schedule. And all the last bullet says all of the accrediting organizations, whether Joint Commission or the others, follow CMS. So if CMS was not budging on the idea of PM completion, the accrediting organizations were not able to budge either. And they have all those accrediting organizations are now following these waivers from CMS. So it really covers pretty much everybody. So these are in force. The name of this document is in the second bullet, this long, complicated thing. As Frank was saying, there have been a number of updates over time. I think the May 15th is the latest. I just checked this morning, but you could periodically just search for this text or for the URL that's below it and see if there are any updates, see if there's a later version. But I would not expect much change, certainly not in the PM area, but you can check and stay tuned to your professional associations and good organizations like PartSource that are bringing information out to everybody when something changes. So you can go to that link and you can get a copy of the document. And next slide. So this is the top of what it looks like, and I'm not expecting you to read all of this because I'm going to tell you the key things, but this is important. On the top of page 1, there's some information that's important to understand, and here are the highlights of that. Next slide, please. So, as I said, there, May 15th is the latest that's online. It's 40 pages long. Part of one page is relevant to HTM work on PM. So focus into that here. It was effective on March 1. They make a point of it being reactive because they didn't even get around, CMS didn't get around to issuing this till after March 1, but they retroactively made it effective. So, you know, ready, fire, aim, I guess, is how they do their work. And the end date is called just the end of the emergency declaration. And it was surprisingly hard for me to get down to exactly what was the emergency declaration, because states are making declarations, the federal government has made a number of declarations, some coming from the White House, and it was difficult to determine when they started, when they ended. And I've dug down, and next slide. This is what I found. It is formally, the formal term is it's a public health emergency declaration, a PHE, from HHS. HHS is the Health and Human Services Division of the federal government. CMS is part of HHS. CMS is part of HHS. And so this is the emergency declaration that this waiver document is talking about. And it started in January. It was renewed on April 26th. And so 90 days out, now they could extend it, they could shorten it, they could do anything they want, but right now it's extended 90 days from April 26th, and that puts it late July. And I don't feel 100% comfortable that I calculate days the same as the federal government, but sometime late in July, this is scheduled to elapse. But we've got some time because we're late May. We've got a couple of months maybe. So, okay, next slide. The other thing I want to put out is that the difference between waivers, CMS waivers, and CMS blanket waivers. This is a blanket waiver. Regular waiver, not a blanket one, you have to apply for. And I see one of the questions we've got in the Q&A board over here is about a thing called 1135 waivers. There were some, and they're still in effect, some things called 1135, waivers, mostly about facility management. Those you have to apply for. It's not difficult, but you have to contact CMS and say, I am applying, and get their approval. That's a regular waiver. Blanket waivers, which is what we're talking about today, do not have to be applied for. You do not have to notify CMS. They're just there. They're in place. So everything we're talking about today, it's already done. You don't have to do anything to take advantage of it. So next slide, please. So if you dig down all the way to page 25, you get to this material. And again, I just want to show you what it looks like. And in the next couple of slides, we'll talk about exactly what it says in there. But when you decide to read about it, get that document, flip over to page 25, unless you've got a lot of spare time to read about the other stuff. So key things. In that document, they refer to inspection, testing, and maintenance, or to ITM. That, in our world, is PM, planned maintenance, scheduled maintenance, things we do on a regular basis. So this is all about PM. It applies, as Frank was saying, to a lot of different organizations. This particular section that was on the previous slide, it focuses on hospitals and critical access hospitals. Critical access hospitals are small, typically rural hospitals that have some special provisions because they are critical to providing access in their geographic region. So those of you who are in critical access hospitals or are part of systems that have critical access hospitals know what I'm talking about. Summary of the second bullet. It's really about hospitals and some similar kinds of facilities that have to do some kind of PM. And what it specifically says that facilities are permitted to adjust their scheduled ITM, meaning PM, frequencies and activities for facility and medical equipment. So the part we're interested in is the medical equipment piece. Some more CMS jargon is this. PM activities, if you have a procedure, a PM procedure, the kind of thing that you find in the service manual, there's a bunch of steps that you're supposed to do. Maybe a series of 5 or 10 different tasks. Those are the PM activities. They're the things that you do as part of that procedure. And then PM frequencies is just when those activities are supposed to be done. And that could be quarterly, semi-annually, annually. It could be, in the case of ventilators, it might be after you overhaul them after a certain amount of runtime. However, you choose to decide when to do a particular PM for activity, that's PM frequency. So I go into that with a little detail because what it says is you can change either or both of those. You could look at a PM procedure and say, I'm going to change the frequency. I'm going to do them less often, or I'm going to not do them at all for a while. And we'll talk about how you would make some of those decisions and document those decisions. But the idea is this CMS blanket waiver gives us carte blanche, free rein to make these changes. Okay, next slide. I'll apologize in advance. I made up this pun-like sort of slide title. So what I mean is, what are we going to do with these waivers? now that they're in place. So next slide. So I suggest that, and I've seen some people do some great work in this, make a policy for how you run your HTM program during the pandemic. It's going to be different. It's going to take advantage of waivers. It's going to take into account a lot of different things. Write it down. You don't have to be formal and fussy. You don't have to use fancy words. Just say it. You know, in the times I've worked with HTM programs on writing policies, I would say, you know, just ask somebody to transcribe what you say. If I say to some person, how are you doing things on this particular aspect of your HTM program, they always come back with a smart, clear, simple explanation of what they do. Just get somebody to write that down. But here are some of the points that I think would be worthwhile considering to put into this pandemic operations policy. And one is to define what you mean by an emergency or pandemic, or how this set of special operations gets into place. When does it start? When does it end? Who decides? There's no standard way to do this. You can decide. You can say, I go to the EOC committee, whatever. But put down what it means. Here's the period of time where we are doing something different. You can put in here some of your emergency practices, like using PPE, personal protective equipment, if you're staggering work shifts, or you're splitting the shop into two to limit transmission of virus, or whatever you're doing. Put that into place, just write it down. And then talk about your priorities. And these are some examples. You make your own. I mean, the priority early on probably was keep the vents working. Maybe you shift that a little bit now, and you know, other kinds of things are more important. You will defer some types of PMs. What kinds? Just write down, I put low priority, I put low risk PMs off, or whatever. Whatever you want to say, just have some reason that you're thinking through. What am I going to let go because I need to focus my limited resources on more important things. So put some stuff into this policy about how you're planning to run things. I would also suggest that you put somewhere, and it could be very brief because we don't know exactly, but the last bullet point, what do we do when we get back to normal? Do we try to make up those PMs? Probably not. How do we swing back into normal operations and start using the standard rules? Who decides when that starts? How do you monitor that? Whatever you want to say, start thinking about what, you know, we're going to get through this one of these days, and we need to move back into that smoothly and not just say, wow, that's over, and then say, now what am I going to do? So think about that a little bit ahead of time. You might want to talk to your emergency management people. They are very good at talking about these different phases of handling emergencies, and so they may give you some ideas about the best way to proceed on this. So next slide, thank you. Anticipating me because I paused long enough, thank you. So how are you going to decide how to prioritize PM? So I'm going to suggest that the first thing you do is use some AEM principles, AEM, alternative equipment maintenance principles. So I hope pretty much everybody knows AEM, is doing AEM. If you're not, you're leaving a lot of money on the table. So look into that. The key points I want to suggest here are that you do some kind of risk assessment. Doesn't have to be formal. It could just be that, you know, everything that is at some risk level, low risk level, I'm just not going to worry about PM for them. Whatever you want, but show that, you know, in your thinking, think about, I'm not just trying to offload work. I'm trying to put my resources where they do the most. So attack the higher risk, let the lower risk things go, or however you want to think about it. And document what you do. A formal AEM program has a lot of documentation. Documentation in this emergency might just be a paragraph. I decided here's 2 sentences about how we are thinking about things in terms of PM prioritization. The other thing I've seen some places do, which I think is a good idea, is to make some changes in your CMMS, your computer software database, if it's easy to do it. For example, now we have all implemented some way of closing a PM work order that the device was in use. So we didn't do the PM, but we tried. Could not locate. We tried to do the PM, we couldn't get it done, but it's okay because we looked hard. Whatever your policy is, I've seen some places temporarily probably put in a new closing code, deferred due to emergency or pandemic or whatever you want to say. So it's a way to keep track that I didn't just blow off this PM. I, in my policy, said during this emergency, I'm not going to do PM. And you could check it off so that it was at least thought of. It wasn't just ignored. This is probably something that some supervisory or clerical person can do rather than tie up frontline technicians doing it. But it's a way to document that you're doing what you said you were going to do because you had good reasons to do it. So next slide, my last slide. Next steps. So right now, I would say, now you put your policy in writing. Probably a good idea to run it by the EOC committee. I don't know if I'd wait till the next meeting, excuse me. I might just walk down to the safety manager and say, does this look okay? And but get somebody else to look at it. Then follow your policy, whatever it is, and do some degree of documentation that you did what you said. So you can see what I'm thinking ahead for is the next time you go through a survey from Joint Commission or DNV or HFAP or CMS or whoever, you can show I wasn't just making it up as I went. I had a policy, I followed it, and I can show you. So think about that. Soon start planning for how you get back to normal. It's not that far away. Decide how you're going to get back to normal and when the magic date is that we are now returning from emergency to normal. And the last couple bullet points are ones that we really don't have time to talk about today, and I don't really know what I'd put there. But you know, this is going to happen again someday, hopefully a long time from now. Hopefully we're better prepared. It could be soon if there's a second wave of COVID-19 cases. It could be far away. Who knows what the next thing is, and it won't be exactly like the one we are just going through. But think about the future. Your hospitals will be doing a lot of emergency planning around this. Be part of that, and or just focus on your HTM operations and say, what did we learn? What did we learn ourselves? What did we learn from talking to colleagues? What will we learn when the articles and stories get published? What can we learn to make the next one go better? So I just leave that as food for thought right now. So that's the end of my prepared remarks. I would love to hear what you all are running into and what you all are doing, and any questions that you've got. I'd be glad to see if I can tackle those. And Frank, too.
Thank you, Matt and Frank. So at this time, audience, I would like to remind you, you can submit your questions using the question section of your control panel. I know some of you have been submitting them as we've gone through the presentation. We're going to take the time to answer as many questions as we can, and we'll give a few more minutes for questions to come through. Again, if for some reason your question does not get answered during the call today, we thankfully the system records who's asking the question, so we'll be able to get back with you individually after the event. So hold on just a moment, I'll tee up questions. One of the first questions always happens during webinars, will these slides be sent out? Which you will be receiving, everybody who registered for this session. You will get an email within 2 to 3 business days, maybe even as soon as tomorrow. It's just as fast as we can get the recording put together. But you'll get an email with a link to the recording. And then Matt has also included in the presentation the link to this CMS document, so we'll include that link there as well. So the first question we'll tee up to the speakers. Do hospitals submit a separate 1135 waiver if the states we operate in already have submitted?
I don't know the state level question, but I'm watching the screen over here. So the particular things we talked about today don't require an 1135 waiver. So probably, I think that question popped up before I got to that slide. If that's not clear, please raise the question later.
Okay, and then I don't know if you saw that second question there, Matt, is again dealing with state and the 1135. So I think that you've probably answered that one as well. Another one says, we have not seen a document allowing hospitals or CAH to adjust IPM schedules for non-imaging equipment or life safety devices. Can you confirm? Joint Commission only announced changes for MRI, CT, PETs. CMS has not approved IPM/ITM adjustment for fire, life safety devices.
Okay, let's unpack that. And it's a good friend of mine, so if you know who you are, if I don't answer this well, let me know. So last one first, life safety, fire safety. I'm less up to speed on those, so I don't know. You could read through this latest blanket waivers document and see what flexibility there is there, and I would recommend contacting ASHE, the American Society for Healthcare Engineering, ASHE.org, and they're keeping track of these facility management things. So the business about 1135 and some other things that Joint Commission came out on its own, in my mind, have been superseded by this particular blanket waiver document. There were some limitations. There were just focusing, for example, on imaging equipment, non-imaging equipment. But the latest in the document we've been talking about today is just medical equipment. So, and it does specifically include critical access hospitals. So my interpretation, I'd be happy to be corrected if I'm wrong, but my interpretation is it's all open, all the medical equipment, which would include imaging equipment.
Next question, should one assume that in the list of covered entities that freestanding emergency department medical devices are included in the waiver?
I think so. Here's where I'm going with that. I think most of those are part of your hospital's accreditation and CMS compliance with CMS conditions of participation. So I would think, since it's sort of all under one umbrella, that it would apply. I have not dug into that. Let me look quickly at I'm sorry, I would have to read more deeply into that. So follow up if that doesn't cover the question for you.
Okay, and I'll give you this the person who asked the question. I'll give you that name too, Matt, if you want to do a separate individual
Yeah, that's fine.
follow-up, or
And I
and
know
vice
him.
versa.
I know him, and it's a very
Um,
smart. It's a very smart question.
So next up, do you recommend updating the emergency operations plan to reflect potential changes in PM activities?
So, so this is just off the top of my head as a consultant. I would say not to formally change that at this point because you got other stuff to worry about. Write your own interim. The emergency operations plan people may be writing some interim stuff. I would suggest part of the returning to normal would be one of many things would be, do we need to formally update our emergency operations plan or not? I think we're fine. You're fine to operate in an emergency basis for now on the basis of these blanket waivers that don't require a modification of the emergency operations plan. But I'd want to pick that back up after things get back to normal.
Next up, how long after the end of PHE can we catch up with PMs?
Yeah, and so that's a great question. Some of the earlier material from the Joint Commission and some other accrediting organizations basically said you got 60 days to catch up. I don't see that in this blanket waiver, but it's probably a good rule of thumb. So part of your planning to return to normal, you should probably think, let's get back into some semblance of normal in 60 days. Sounds like a good number off the top. Again, you're going to have to think about, does that mean you catch everything up, or you just ease back into the routine schedule? I have not seen any direction on that, but it's something to think about.
And this next question gets kind of particular. We had ventilators that were due for PM, but were on patients that were positive with COVID-19. The patients needed to stay on the vents. Is it acceptable to put deferred due to COVID-19 in CMMS under PM work order?
Sure, I think that's a good idea. So it's a good example, though, of when you're thinking about returning to normal, you may have some important things like ventilators that are way out of date because they were so in use for months. And maybe you prioritize getting those cleaned and PM'd ASAP.
Okay, next question. Getting, quote, back to normal, quote, will require the return to revenue production for our facilities, which could lag behind the government proclamation that the state of emergency has ended. Would you recommend an application for an individual 1135 waiver for additional time to recover for the impact of the pandemic, the lag due to furloughed employees, forced PTO, cut in paid hours, ...
Yeah, so it's a good point. Who knows how long it's going to take a while. Things are not going to just snap back to normal. My sense about the 1135s is you probably should go ahead and apply for anything that you can apply for that gives you some breathing room so you can do what makes sense in your organization. My sense is that the facility management people in your organization have been paying very close attention to the 1135 waivers, and they've probably got that all queued up, ready to go. So you might just, latch onto that process and give yourself as much leeway as possible.
Yeah, and I would say I'm kind of a layman, but I would think different facilities or different parts of the country are going to be affected differently. Would you guess the same?
Sure. I mean, it makes a lot of difference where you're at, and you should take that into account in your local planning. So I'm in Colorado, and we have not seen the same kind of stress that, say, New York and New England or California have seen, and so the things we're up against are different. So yeah, for sure, take into account what you can with your local circumstances.
Okay, we have a few more questions I hope to squeeze in. Again, anybody who's having to drop off, you will be receiving access to the recording and the document in the follow-up thank you message that will come to your email. So we'll continue on with these questions for a few more minutes. Next one, if we are unable to perform IPM or ITM, we're documenting the appropriate response code in the CMS. If due to COVID, we have to change frequency, that is being documented with our AEM tool. Will that suffice?
Sure. I think your AEM tools are a great way to do this. If you don't have a full running AEM program, you can still take advantage of the waiver with less formality. But I will tell you, I'm a big advocate of just making the AEM way of thinking the standard way we do business. It's a way to let us focus our limited, we always have limited resources. They're just more constrained than usual right now. So we should always do our best to have a rational, documented way of making sure we take our limited resources and put them where they do the most good.
Next up, a question from Rich. Like the right to repair activities, are there other thoughts around limiting the control of the state, local government from restricting operational approach of the hospital or healthcare organizations?
I don't know. The right to repair is the one I've focused on, and it's kind of a sideline to what we're talking about today. But you know, if we did, so it may well be that you have some opportunities to, through your your hospital association, or through your professional, your biomed association, do some advocacy work within your state or region to apply some lessons learned. I don't know what those would be. I think it's a great opportunity because, you know, we certainly are all sensitive to the need to do better.
Agreed. This next question is pretty fitting. I think we're all probably wondering. A question from Rick. There is a strong feeling that we may endure a second wave of COVID-19, he says, next winter. Assuming this does happen, do you think CMS will be proactive to help HTM departments deal with this?
It's an excellent question. I don't try to predict CMS. What I would do, though, is before CMS got around to any of these waivers, and before even Joint Commission and some others and the 1135 waivers and all of that stuff, hospitals were already saying, I can't keep up. And some people were, the really proactive ones were already saying, laying out an emergency operations plan for HTM, following different rules, and you talk to them in private, they would say, I can't wait for CMS, I can't wait for Joint Commission. This is the reality on the ground. I'm going to do something sensible going forward, tell people what I'm doing and document it. I don't think I can officially recommend doing that. I would say as an individual, maybe even as a consultant, I would say you do what you got to do. And if we get into this bind again and there's some reluctance on the part of the regulatory agencies, do what you have to do, but keep track so people can't come back and say you're just trying to get out of work. Have some reasons, write it down, do a rational process. But I think, you know, you can't always wait for bureaucracies to respond in a timely manner.
Thank you, Matt. This next question, it's referring to something that it seems a bit maybe aside from what we were talking about today. It says CMS and Joint Commission have adopted NFPA 99-2012 as code.
Yep.
In that there's a section for service documentations Joint Commission also added EP for documentation library. Can these
Yep.
be accountable during a survey?
So it's tough. So NFPA 99 2012 edition certainly says that, and the Joint Commission echoes it in its standards. There's no way you can force the manufacturers to come up with that documentation. What I've heard from surveyors is all you can do is say, I did my best to try to get the information, and that's all I can do. The only one other option is, to the extent you can, don't buy stuff from companies that won't cooperate, but we know that's not always possible. Get behind the right to repair movements. So we're in a bind right now where everybody knows what the right thing to do is, but we can't do it right now. So I wouldn't worry. Do your best and document that you did your best, and you should be okay during survey.
The last question, it kind of alludes to the same, well, there's another one coming in. Well, we're going to answer this last one, and then we'll probably have to answer the others online. Have you observed any changes in work of HTM that might have lasting effect even after the end of the emergency declaration?
I haven't thought about it in those terms, but I would say now that there are a lot of people saying, I really can't wait any longer. I can't just follow manufacturers' recommendations for PM, so I better have some kind of a sensible process for managing that. So, for example, time to get my AEM program cranked up. The other operation, I don't know. I don't know the answer. I've not heard a lot. I look forward to hearing a lot of ideas coming from us. So publish, go to your local biomed groups and talk, give a presentation, share the information. So a lot of smart thing is being done. A lot of smart stuff is being done. So let's share that and get smarter.
So Matt, I'd like to just add a little thing on that one. Yeah, thanks for all those great comments. You did a wonderful job handling all the questions. Yeah, as I was reading the waivers document, it dawned on me that there were a lot of common sense things that CMS was allowing the hospitals to implement. And admittedly, we have a lot of documentation and a lot of ways of doing things for quality, but in this emergency, we're sort of experimenting and going out maybe on thin ice. So as I was thinking about this, I was thinking that there may be things that we will be thought of differently in the future that were now being implemented because of the emergency. So I'm going to guess yes, and certainly the technology changes that we discovered in, like for instance, in telemedicine.
Agreed.
Will definitely have an effect in the future.
Agreed.
Right, I believe so too, Frank. Thank you guys both for those answers of the questions and for the presentation. So at this time, to all our guests, I would like to thank Matt, Frank, and Joe, and you, all of the attendees, for your time today. As a reminder, you will receive a follow-up email. It will include a link to the recording, as well as a link to that CMS document. We hope to get that to you guys in 2 to 3 days, hopefully as soon as tomorrow. It will be coming to you via email to the address with which you registered. And at this time, our webcast is ended. Thank you all for attending, and I hope you have a wonderful day.
Take care, everyone.
Thanks. Bye-bye.